So just a little bit more of the case. Post-op, Mrs. Tabulum has increased confusion and exhibits signs of delirium. Knowing post-op delirium is common in the elderly and can lead to poor outcomes, the team decides to involve a geriatrician. Please welcome Dr. Von Maltzen.
Is that loud enough? Good. So thank you very much. I'm thrilled to be here today. This is certainly bread and butter work for me, and it's a topic that's very near and dear to my heart because it is a very common issue and one where I think there's a lot of work that we can do to help patients through their hip fracture experience from a geriatric perspective. So I need to start with some acknowledgements. First, I'd like to thank the Dartmouth General Hospital Foundation and Mrs. Burns for the invitation to speak today, as well as to Carla for organizing and inviting me. And I really do also need to thank one of my mentors, Dr. Camilla Wong, who has presented on this topic. And Camilla's very skilled at creating graphics, and she very generously allowed me to use a number of her graphics in my slides. And I didn't know if I needed to disclose anything. I never have anything to disclose, so I just put that out there. So my goal today is to talk about the perioperative guidelines for older adults, and then I'll also talk about the guidelines for postoperative delirium. And along with this, we'll discuss some delirium recognition management strategies, and I'll try to point out some useful resources for families and providers as well. So it's always really nice, I think, when there are guidelines to help set kind of a benchmark for us in terms of our work. And the two guidelines that I'd like to point out, actually I'll point out three, but I think these are really useful documents to download and have as easy reference. So they are guidelines developed by the American College of Surgeons National Surgical Quality Improvement Program in conjunction with the American Geriatric Society for the optimal preoperative and perioperative management of the older surgical patient. And along with that, the American Geriatric Society also has guidelines on the management of postoperative delirium in older adults. And it's in fact such a special topic that it has its own special article. And it's an important topic for at least three reasons that come to mind. The first is that it's in fact very common, arguably one of the most common complications for older patients who have undergone a surgery. The range for the estimate in terms of the frequency is pretty broad, but at least up to half of patients can have a delirium in the postoperative setting. It's also a very serious complication. So surgery really does represent this important moment in an older adult's life where their cognition and function can be altered, not just in the short term, but also the long term. And a lot of that is related to the serious impact that delirium introduces in the post-op setting. So delirium has been associated with loss of function, impairments in cognition, as I said, not just in the short term, but in the long term. And it's also associated with higher risk for institutionalization as well. And the last, not just that it's common and important, it's preventable. So we can actually prevent delirium in up to 40% of patients. And so with that in mind, I think that really puts or gives us a motivation to try to do as much as we can from the outset to avoid delirium when we can. And how do you do this, Maya, you might ask? Is this magic? It's not magic. So my tool of the trade, it's a little different than Dr. Legay's scalpel, but it's, I think, very skilled at dissecting the whole picture of the patient in terms of their medical, psychological, and functional capabilities. And so those components are going to inform my comprehensive geriatric assessment. And when I go through those different domains, I can then develop an integrated plan for treatment and follow-up. So this is a picture of the perioperative continuum. So Dr. Legay has talked a bit about the preoperative period. I'm going to touch on it a little bit as well. I won't talk too much about the intraoperative period. I'm happy to answer questions about that. It's certainly guided by anesthesia, surgical expertise largely. So I'm not going to delve into that today, but then after we'll also talk about the postoperative period. So this is just to highlight that, yes, we're going to focus on the preoperative period to start. And the preoperative assessments have three components that I'm interested in. So the surgical risk assessment, again, I'm not going to talk about that too much because it was covered in Dr. Legay's talk, but I will touch on the values-based assessment and the geriatric risk assessment. The values-based assessment will be that stage where if geriatrics is involved early on, we'll take time to help establish that substitute decision maker, explore goals and preferences, and then document code status. And I like to also point out that sometimes if somebody has do not resuscitate guidelines, we can sometimes in conversation with anesthesia and orthopedics, depending on the individual, it might be appropriate to slightly modify that for the intraoperative period and then return to the usual code wishes. And Dr. Legay also did touch on capacity. Sometimes capacity, that word just stresses people out, and the point of this slide was just to say that it's actually, it shouldn't be too complicated. It's really two components, and it's just looking to see if the patient understands the information needed to make a decision about proposed treatment, so in this case a surgery to fix their hip, and whether or not they can appreciate the reasonable consequences of proceeding with a surgery or not proceeding with the surgery in this case. And so I think given that there were some concerns about Ms. Tablam being potentially a bit delirious, a mild delirium in the case that was presented, having a substitute decision maker involved would be helpful. I do think even if somebody is confused, you can still often gain information from them about, what their wishes are, what their big concerns are in that moment. And I added on as well. So I imagine that we did ask Ms. Tablam what matters to her, and she really does voice that. She's in a lot of pain, she just wants to be out of pain, and she wants to be able to walk again. So it really does seem quite sensible that she's had this surgery to help fix her hip. No, I don't know of any geriatricians who are able to avoid a talk without mentioning frailty. And it's not just that. We're very lucky in Nova Scotia to have really one of the world experts in frailty research, Dr. Rockwood, in our neck of the woods. It's certainly relevant, globally to anyone who's looking after older adults. And this is because frailty represents a state where a person is very vulnerable to any adverse health outcomes. So this picture here highlights that if you're really robust and healthy, it's going to take a really big medical stressor to impact you or to make you even sicker or to have an unfavorable surgical outcome. If you become pre-frail or indeed very frail, only a minor health stressor will make you at higher risk for an unfavorable surgical outcome. So somebody who has severe dementia, that hip fracture is going to be a really significant event, and the stress of the procedure itself could put them at high risk for an unfavorable outcome following the surgery. And there's really quite a big body of evidence highlighting that frailty is significant for mortality after surgery, with increased 30-day mortality and 1-year mortality. Post-operative complications are higher in those who are frail, And then from a discharge perspective, those who are frail tend to have longer length of stay in hospital and higher likelihood that they're going to be discharged to long-term care. So this is the graphic representation of the clinical frailty scale that Dr. Legay mentioned. And it's really quite a useful scale, and I think that's also reflected in how it's even implemented in the preoperative assessment papers. So it's nice in that it's easy to use, and it's informed by history that's fairly readily gathered, or easily gathered when you're speaking with patients and their families. So it's all based on what that baseline function was like. Those who are in the clinical frailty scale of 5 through 7, that's where frailty is becoming more significant, and those are the folks who are more dependent on others for their day-to-day function. So as part of my geriatric assessment, I'm very interested in function, and function is going to be informed by the activities of daily living, including the instrumental activities. So those are the higher order, tend to be potentially harder tasks if you have some physical or cognitive difficulties. So that would be your medication management, looking after finances, driving, shopping, cleaning, etc. And then the basic activities of daily living, so toileting, getting dressed, feeding oneself. Other aspects that are important would be continence and baseline mobility. I'm always very keen to know about vision and hearing and swallowing problems, because if there are problems with those early on, well, there will likely be problems afterward, and that may be an avenue where we can intervene or provide adaptive equipment. Falls is important, and that will also encompass the falls history related to the current event that's brought the patient into hospital, as well as mood. And cognition has its own screen, or its own page. So screening for cognitive impairment is also very important. Certainly many people who present could have potentially early changes in their cognition that wasn't really detected or known about before until the questions are asked. So ideally, and this may be more related to, or more relevant in a say an elective orthopedic procedure, other kind of surgical procedure, but I do think it is helpful to ask about memory concerns, performing a screening assessment like a mini cog, and in that case you're asking a patient to learn 3 words, repeat them back, say ball car man, draw a clock, and then recount those words again. And if there's abnormalities there, then you might want to do more screening. And then, of course, the most important part is just documenting that, because if there were any concerns, or actually even if somebody's normal before their surgery, you really want to know that in case something changes after the surgery. And I won't talk too much about the medical optimization, mainly to say that it's certainly an important part preoperatively, because it does tie in with potential risk for postoperative delirium. And the one other comment to add here would be it's important to ask about any substance use, alcohol, not just the smoking cessation, but thinking about withdrawal as a risk for delirium in the post-op setting is important. So coming back to the case, as we learned on post-op day 2, Miss Tablum becomes more confused and agitated. She's calling out, pulling at her IV and her oxygen tubing. She doesn't seem to have pain, and this is correlated with clinical assessment. She's not rubbing her hip or calling out when she's being repositioned. Some preliminary tests are done. Her urine is negative for any growth of bacteria, and her chest x-ray is normal. Her vital signs seem to be stable. She doesn't have a fever. So my job now is to think about what might be going on in the postoperative setting that could be precipitating and potentially prolonging a delirium. So just coming back to this perioperative continuum, delirium often becomes a concern postoperatively, along with pain and falls, nutrition, function, and of course this is also introducing the concept that our interdisciplinary team is going to be really important as well. So, in terms of the approach to the management of postoperative delirium, I know this is a very busy slide. I'm going to focus just for now on the predisposing factors. Whenever I see a patient for postoperative delirium, I like to take myself through the exercise of thinking, what is it about this particular individual that has put them at higher risk for delirium? And there are actually quite a few potential risk factors. It's hard to avoid getting older, but age is one of the biggest risk factors. And certainly as we go along in our decades, the risk does increase. The next big area that I think about is anything within the brain. So cognitive decline, dementia certainly drastically increases the risk for postoperative delirium. But that would also include any prior stroke history, intracranial lesion like a tumor. The next big aspect are whether or not there are any sensory deprivation issues. So is this somebody who has chronically poor vision, even with their glasses, or do they have any hearing impairment? Because I think it's very intuitive, if they can't appropriately interpret their environment, that puts them at higher risk for confusion. There are other aspects as well: chronic pain, psychiatric history, substance use, certain medications, like if they're on chronic opioids or benzodiazepines, and whether or not they're already really sick or there's an infection. Certainly if they're somebody who's dehydrated as well, those would all be predisposing factors that make them at higher risk. And I think that's just saying the same thing. With respect to hip fracture patients, this was actually studied, and there are predictive tools. This researcher, Dr. Marcantonio, has done a lot of postoperative delirium research specific to the hip fracture population. And in his predictive model, age greater than 70, alcohol misuse, poor cognitive or functional status, those electrolyte imbalances, and then if actually the surgery was one of those really big surgeries like non-cardiac but thoracic or aortic aneurysm surgery, those actually put people at higher risk. And delirium prevention now becomes important because it's going to align with also our management strategies. So you can't avoid talking about delirium management without thinking about the preventative strategies. And I think this slide's actually easier to think about because it captures it all with just eight big categories. So one, thinking about sensory impairment. Does the patient need glasses that they normally have, and maybe those glasses are at home, for example, or hearing aids? And then thinking about cognitive stimulation and orientation. I think we can all imagine how a hospital environment can easily become disorienting, particularly if you're in a room without a window, hard to tell if it's day or nighttime. Thinking about fluid and nutrition. So is somebody dehydrated? Certainly in our case, that sounded like it could be a concern. Communication can be a big aspect as well. If somebody's first language is not English, if they have any kind of communication barriers, that can potentially be a way where maybe speech-language pathology might have strategies to help enhance that. Mobility enhancement, addressing sleep concerns, looking at medications, and thinking about pain control are also all important. This probably is my favorite slide of all because it empowers family, or it speaks to the evidence for empowering families in this aspect of a patient's care. So when they studied these delirium, giving patients' families the information about the delirium prevention components, it only took teaching 13 families to prevent one episode of delirium. That's pretty good. There are a lot of medications that have a much worse number needed to treat. And so this really, for me, just reflects the importance of informing families about delirium, telling them what they can do, and including them in the patient care as well. This is an example of another delirium prevention bundle called the Hospital Elder Life Program. And it's really one of the landmark studies that informed which components we highlight. And the other thing I often mention in conversations with other clinicians or families, these are all very common sense things. Sometimes I think people have a hard time believing that, having somebody's glasses at the bedside or in place, fluid available at the bedside, that it can make that big a difference, but it's been shown in the literature to really be that important. And this, again, was, as I mentioned, studied by Dr. Marcantonio in a randomized control trial that was published in 2001. And in his study, he had a geriatrician involved in the care of patients with hip fractures. And the geriatricians would come every day, and this was within either preoperatively or within 24 hours postoperatively. And the geriatricians had a structured visit where they would check oxygen delivery, fluids and electrolytes, assessment of pain, medication review, thinking about bowel and bladder function, nutrition, that early mobilization, and of course the medical piece, any prevention or recognition of postoperative complications, as well as recognition of delirium. And all this to say that these multi-component strategies really do reduce the incidence with a relative risk reduction of about 0.69. So moving on to recognizing delirium. Delirium represents an acute state of confusion. The gold standard for diagnosis would be the DSM criteria, but I think for practical purposes, one of the most useful tools is familiarizing yourself with the confusion assessment method, or the CAM. So on my notes, you may see me writing CAM positive, CAM negative, and that just speaks to whether or not somebody is delirious or not. There are 4 components. You need both 1 and 2, plus one of either 3 or 4. So everyone, in order to diagnose delirium, there has to have been an acute onset with a fluctuating course and a component of inattention, along with either disorganized thinking or a change in their level of consciousness. And the fluctuating part is also important to make note of, because sometimes somebody, if you see them in the morning, might seem really good, but then by 4 p.m. they're restless, agitated. And so to me, just because I saw them well in the morning, they're still delirious in my mind, because the afternoon is now presenting this period of fluctuation. Sorry, this one might be a little bit tricky to read, but this is really just to say that while the previous slide represents those core features, there are other additional supportive features that might suggest that somebody's delirious. And in all of these cases, it's important to find out whether it's new or not, particularly to differentiate between somebody who has an underlying dementia and a new delirium. So in folks with a new delirium, they can have psychotic features like hallucinations, delusions. They may be more paranoid in their thinking. Their movements might be more slowed down, or conversely, they could be more agitated and restless. Very often, that normal day-night pattern that our healthy brains keep intact for us can be lost. So people might be awake at nighttime and sleeping during the daytime. There may be new incontinence. And because there's confusion, mobility and physical regulation often declines as well. So those folks often are at high risk for falls in hospital. I also wanted to just highlight that there's 3 different phenotypes of delirium. The one I think that usually comes to mind is that agitated, restless patient who's pulling at their lines. But the folks who really worry me are those who are more somnolent. You go to talk to them and they're kind of, their eyes are closing, they're not able to sustain attention. Those people have a hypoactive delirium, and those are people who are actually very sick and are at high risk of dying. So they need to be recognized early as well. Many people actually kind of fluctuate between the two, so that might be the person who's restless and up at night, but then sleepy and drowsy during the day. So now moving into what has precipitated a delirium, and then also what could be prolonging the delirium. For the precipitating factors, in this case, there are some really obvious ones that Mrs. Tablam's had a fall, she's had a fracture, she's undergone a big procedure, but we have to think about whether or not there's anything else contributing, and that's going to be guided by our comprehensive assessment. So we will want our vitals, blood glucose, we're going to ask history, and at the bedside, look for any focal symptoms, thinking about pain, yes, any new organ-specific symptoms. We'll go back through the chart and think about the social history again, thinking about maybe, did we miss that Mrs. Tablam actually has, half a bottle of wine every night, and she's now going through alcohol withdrawal. We'll also look at the medications, do a physical exam, check to see that the surgical site doesn't look infected, although I know our orthopedic colleagues are checking that as well. Thinking about any signs of retention, and that counts for both bowels and bladder function, and then initiate an early investigation series. So that will be the CBC, electrolytes, creatinine, and urea, extended electrolytes, sometimes liver enzymes, and then thinking about infectious etiology, so blood, urine, cultures, maybe a chest X-ray, which we heard was done. In certain cases, we might also want to do things like troponin, BNP. Sometimes a CT head might be indicated. And just a brief note about medications as precipitants. Another tool to familiarize yourself with is the Beers list of potentially inappropriate medications in older adults. Hard to memorize the whole list, but I'll touch on some of the ones that are more relevant to the perioperative period. It's always better if somebody's able to take oral medications, and Dr. Legay mentioned this as well, that we want to try to move away from the IV, IM, or subcut opioids to anything oral. And don't forget to think about what might not be there. So in the similar example, perhaps Mrs. Tablam was taking lorazepam that was in a separate bottle, and she's been taking that every night for 20 years. That would be another potential medication that she could be going through withdrawal. And just in general, starting more than 5 medications in and of itself is an independent risk factor for delirium. So for the syndromes that might come up in the perioperative period, nausea, I do often start with ondansetron. I know Gravol is sometimes a more effective medication for nausea. The challenge is that Gravol is very anticholinergic and carries a high risk for delirium. So if somebody has nausea and Gravol does feel like it might be the better medication, I strongly advocate for just a dose adjusting to 12.5 milligrams, which is a little bit of a lower dose, a little bit more friendly for the brain and health of a frail older adult. And I try not to give it any more than every 6 hours. For pain, that should actually say start the scheduled acetaminophen 975 scheduled, and I think anywhere between 3 times a day to 4 times a day is reasonable, certainly no more than that because you'd be exceeding the limit. There is a goal, of course, to reduce the opioids. Sometimes a very low dose of oral hydromorphone can be quite effective, and particularly if it's timed before the physiotherapy session, that can be very helpful. I tend to avoid NSAIDs, oral ones in particular, because we see a lot of older adults with heart failure, and that can increase the risk for heart failure, decompensation, and exacerbate hypertension. I use a lot of topical NSAIDs like Voltaren. And there is, in fact, more evidence as well for the role of adjunctive nerve blocks. So if there is really intractable pain, it might not hurt to involve anesthesia to see if that might be an avenue as well. Constipation, the first-line agents are PEG or lactulose. I like PEG because it's what they used when I was a medical student on pediatrics, and I think if it's friendly enough for the little wee ones, then it's going to be friendly enough for our frail older adults. And then The second line to add if constipation is still persisting would be senicides. And then just making sure that we're keeping close track of that with stool charting. No evidence at all for DocuSet. And I don't believe it's on the formulary in Nova Scotia anyway, so, or at our hospitals, so that's easy to avoid then. And for sleep, this is a tough one because it's really, we have to advocate, I think, first and foremost for non-pharmacologic strategies, and trying to sleep in a hospital is just really difficult. Sometimes I do have a trial of melatonin, 3 milligrams at bedtime. A very low dose of trazodone sometimes can be effective, but it does still carry an increased falls risk. I do recommend avoiding benzodiazepines, and I don't ever really see a role for zopiclone. It's purely a sedating medication. It doesn't have any other benefits other than making somebody drowsy. For delirium treatment, well, as internists, we're always trained there's a non-pharmacologic answer and a pharmacologic answer. So in this case, non-pharmacologic strategies are really the heart of treatment. So this would be reintroducing and aligning those preventative measures, thinking about the pain management, reorientation, making sure that somebody's senses are optimized, making sure that they're spending some time out of bed, they're not being woken up for vitals at 1 in the morning. They're eating and drinking okay, and thinking about the medications. If somebody is agitated, at risk of causing harm to themselves or others, because we certainly worry about the very agitated patient potentially harming themselves or a nursing staff or other health professional, the guidelines do note that a practitioner can try antipsychotics at the lowest effective dose for the shortest possible duration. And once those are initiated, there really should be some ongoing assessment to see if they are still indicated. All of the antipsychotics do carry an increased risk for stroke, cardiovascular risk, and death. So I try to counsel patients about that, or family members about that. I recommend using the lowest dose possible as well. So I will try haloperidol 0.5 to 1 milligram every 6 hours as needed if the agitation is severe. And again, oral is best, higher risk if you're using intravenous or intramuscular. In select cases, you could also consider risperidone or quetiapine. The studies haven't shown one to be superior than the other, or that any is really all that effective. There is a Choosing Wisely Canada guideline about these as well, specifically not to use benzodiazepines or other sedative hypnotics in older adults as the first line for not just insomnia or agitation, but for delirium as well. And I do always put the caveat about benzodiazepines because not to just throw them out entirely. They are still indicated if somebody's going through alcohol withdrawal. And we also have to be very, very careful with antipsychotics in anyone who has a history of Parkinson's disease or dementia with Lewy body, because they do have quite a bit of sensitivity. So those are patients to just be a little bit more cautious in. So coming back to the case, since the vital signs were stable, Mrs. Tablam's oxygen status was normal, we said, well, let's take away that tether. She doesn't need that. Her exam, she seems euvolemic, so we'll continue to encourage her to have oral hydration for now. I said to change acetaminophen to 975, TID scheduled. To be honest, everyone's really good at getting our patients on scheduled acetaminophen, so that's often not even an option for me to recommend because it's already being done. Given the diarrheal concerns, we'll send her stool for viruses and culture. We'll also get some blood work, and I did also add a celiac antibody there. Some older adults actually can have constipation and then have overflow incontinence with their stools, so we'll get an abdominal plain film, and it's always an easy check to get that bladder scanner out to make sure she doesn't have a big bladder and isn't voiding well. We'll educate her family on delirium education, and I've actually been able to avoid in some cases using antipsychotics after talking with families who say, well, you know what, mom seems okay when we sit here with her, so we'll find somebody who can stay and help with that piece. I made up that she had some hearing aids, and they'll bring those in. And of course, we'll keep following. So this is the post-operative checklist. So thinking about delirium and prevention. It's a multidisciplinary effort thinking about the multimodal pain control and minimizing pulmonary complications. I loved the comment about incentive spirometry as well. I tend to recommend that. But as you'll see, we now also have physiotherapy coming in to help with fall risk. We have dietitians who will help with the nutritional concerns. We'll have physio and OT thinking about the functional piece, and of course wound care and nursing for the concerns about pressure ulcers. So back to our perioperative continuum. It is very truly a multidisciplinary pathway, and we'll hear more about our other health professionals' role. And I think what's really helpful is whatever is good for delirium prevention and management is also going to be really good for falls, for functional decline. So we are hitting many birds with these, let's call them many small stones getting many birds. But the nice part is that they're all really common sense things. Certainly sometimes it's hard in a busy hospital environment to make all of these things happen, but that's where this interdisciplinary team becomes so important for addressing the care needs of these frailer, older people. For resources to give to family members, I quite like this locally produced resource. This is notmymom.ca, and it has a little video as well. I've certainly shown it to patients who and family members who hadn't actually heard about delirium or didn't really understand what it meant, and that can be one way to engage families as well. The Canadian Patient Safety Institute also has really useful care bundles for delirium prevention, and I think that's a good resource to look at.